Hello, welcome to today's webinar, The Changing Conversation in MG. My name's Jenna Imvallo, and I'll be moderating today's session. I'd like to start by thanking our sponsors who made today's webinar possible. Thank you to Alexion, Argenix, Regeneron, Johnson & Johnson, and UCB. Today's session will be recorded and available online after. You can check on the MGFA website to find the recording. If you have any questions, you can submit them in the Zoom Q&A box located at the bottom of the Zoom menu bar, and they'll be answered during the Q&A segment. You also have the option for closed captions, and you can do so by clicking on the little closed caption box at the bottom of the Zoom icon and select English as your language. And now it's my pleasure to introduce today's speaker, Dr. Jeffrey Rosenfeld, who is giving us a wonderful presentation on the changing conversation in MG. Welcome.
Thank you very much. Let me see if I can share here. Are you able to see my slide?
Yes, we can see it.
Great. Well, thank you very much, Jenna. It's really my pleasure to be here, and it's always enjoyable to work with the MGFA and the great feedback that I've been getting. And today's talk, as Jenna mentioned, is titled The Changing Conversation in Myasthenia Gravis. And I presented this talk in a version earlier this year at the National Patient Conference. So for those of you who may have been at that symposium, some of this will be certainly a repeat. But I did make the mistake, which I don't usually do, but I made the mistake of watching my video on the recorded line after that conference. And that's a bad idea for me. And so I wound up changing some things, and you're always more critical of yourself. But it's a pleasure to give this talk again. And really, it's kind of an interesting talk for me because it's a newer idea to present. And it really comes from my own personal experience that I talk to patients who have myasthenia, newly diagnosed and established patients, differently than I used to talk to them. And so for me, as a treating physician, the conversation with my myasthenic patients has changed. But since I presented this at that meeting and actually thought of this concept, the title has meant different things to different people. We're going to talk about that because in very much across the board, the dialogue that we have with each other, with your physician, with your family, the conversation has changed. So see if I get this here. There we go. So I guess if you hadn't heard this talk when I presented it in Phoenix earlier in the year, you might wonder, a conversation between who? And what are you talking about and why has the conversation changed? All of these things we're going to discuss this morning, or this afternoon, but the conversation between who started out very much from my own experience. It was a conversation between me and my patients has changed. Since then, I've appreciated how the conversation amongst myself and colleagues in the field, and they with themselves, has changed, as well as patients' conversations with other patients has changed. Why has it changed? Well, I guess one of the takeaway messages from the talk today will be that we are very much living in an unprecedented time in the development of myasthenia therapeutics and our understanding of how to address this disease. And as a result of that, there are a lot of choices, a lot of options that were not available earlier, and more to come. And that's what really the nature of this talk today is to show you why this is such an incredible time and what's coming down into the future. So we're going to start off with a brief historical perspective about where we are and how we got here in our understanding of myasthenia. I'm going to talk briefly about autoimmunity, something that many of you are quite familiar with, but it's important to understand a little bit about autoimmunity to understand why these different therapeutics, where they're coming from, basically, and when new ones are introduced, where do they fit in? The concept of minimal symptom expression has been around for some time, but it's becoming a very popular concept. And essentially, minimal symptom expression means that the disease is not really affecting your lifestyle. And that is an attainable outcome for many patients that was not the case earlier, or was only the case after a very prolonged period of treatment. And then I'm going to share some interesting current research about patient perspectives and physician perspectives relevant to this change in conversation. And we'll wrap up with what can you do if you don't feel that the conversation is where you want it to be about your condition, your myasthenia. So this is an intentionally very busy slide, and it's a slide that highlights the timeline of both the discoveries in the lab and the introduction of new therapeutics. So some of the earliest descriptions of myasthenia occurred in the 1600s. This is a description from a physician in England who documented a patient that, by all accounts, sounds like they have myasthenia. Now, understand, in the 1600s, we didn't understand what myasthenia was, why it's caused, what the target was, but clinically, this is what it sounded like. There was actually an earlier report of a Indian chief in Jamestown that might have been the first reported case, but myasthenia has been known about for quite some time. Not a lot happened until the 1930s, when a very seminal paper and publication was from Dr. Walker, Margaret Walker, who basically discovered that physostigmine, which is similar to pyridostigmine, mestinon, was of significant benefit. Now, at that time, they weren't exactly sure why it was of benefit or what exactly the action was, but the mechanism of the drug was very relevant to whatever at that time was understood to be the pathophysiology of the disease. And then later, actually 25, 30 years later, it was hypothesized that the disease was caused by an autoantibody. And an autoantibody means an antibody that is generated by your immune system that is targeting, in this case, the neuromuscular junction, the connection between the nerve and the muscle. And that antibody is unwanted because normally we don't target proteins within our own body that are supposed to be there, but it's an autoantibody, and that's why myasthenia is an autoimmune disease. About 10 or 12 years later, a publication came out that showed that, in fact, this antibody could be transferred from one animal to another, showing the pathogenicity of the antibody. And then there were a large number of discoveries through the early 2000s, mostly about the physiology of the receptor, the target of that antibody, and a little bit about the potential for new therapeutics. Now, on the bottom of the timeline, you can see the introduction of the therapeutics. And what this graph, because this paper that I took this timeline from was from 2019, it doesn't really capture that things picked up even to a greater extent after 2019. And I'll show you some of that. But the pace of discovery is, in my experience, unprecedented. So it's quite exciting time now. And I'm trying to give you a perspective as to how to view these current recently introduced products, drugs, therapeutics, and also what's coming in the pipeline. So this is a slide, and it was shared with me by my good friend and colleague, Dr. Ali Habib at University of California in Irvine. I was at a conference earlier in the year, and Dr. Habib presented this and some other slides that I'll share with you. And I thought it was such a great summary, and he was kind enough to let me use these slides for this presentation. So this is a different kind of timeline that shows you some of the clinical trial activity in myasthenia. And the takeaway message here from this very busy slide is there's a lot more dots on the right than there are on the left, which is reflecting the number of active areas of investigation. I'm going to highlight that in a moment, because just last night, I checked in to see how many active clinical trials are there in the world in myasthenia. I'll share that with you in a moment. But some of the drugs that you see on this slide listed are familiar to you, but this is an idea of how it was paced. So there's clearly a sense of picking up steam, so to speak, more drugs approved now than in the past. I'm going to digress for just a moment to give you my 1 or 2 slide overview of the immune system. The immune system is complicated, and so I'll try to make obvious what you need to know. The idea is that the immune system is kind of a chain of events. One thing happens that causes another thing happens that causes a third thing to happen. And secondly, there are more than one way to have things occur in the immune system. So in this particular cartoon, there are circulating white blood cells called T cells. And those T cells recognize often something foreign in the body. It's possible, too, that those T cells recognize some things, as in the case of autoimmune disease, that is not foreign, but the T cell thinks it's foreign. And what frequently happens is the T cell then presents or tells the B cell about the foreign thing that it found, and the B cell produces antibodies. And these antibodies are what actually do the damage. The antibodies, depending upon what the antibody is directed to, mostly interfere with function. Now, antibodies, as you know, are also good because when we have an infection or a foreign body and something that we need to mount an immune response for, antibodies are critical for that. And that's why we like some antibodies. It's just the ones that are directed against your own body in your own proteins, in the case of the neuromuscular junction and other autoimmune diseases, they cause problems. But antibodies are released into the blood circulation. And in the case of myasthenia, the antibody that is directed against the acetylcholine receptor on the muscle blocks, impairs the function of that receptor. And that's why there's weakness in myasthenia, because the nerve and the muscle can't communicate with each other because of the blockage of that receptor caused by that antibody. So if you were to affect the reactivity of the T cell, that might slow down the autoimmune attack. If you decrease the activity of the B cell, that could slow down. If you affect the pathogenicity of the antibody, that is, make it less dangerous, that could affect a positive outcome. And on the bottom here, you can see various therapeutics and where they're likely targeted. So we're going to talk some more about the specifics of some of these, but many of these earlier steroid-sparing drugs, I say earlier because they've been out for much longer, they affect upstream on the pathway, whereas some of the more recent drugs affect a little bit further downstream. And we'll talk again about some of the specifics of these, but I want to give you an idea of there are various mechanisms that are available for intervention to slow down an autoimmune attack. So when a new drug comes on the market or a new mechanism is introduced, it's important to think about where in the cascade of things does it occur. It's important because sometimes the time of onset, and it gives you an idea of the other drugs that are similarly marked. One of the most exciting, and I don't want to overstate it, but I think kind of remarkable developments in the field of myasthenia is not so much in the number of drugs that are being introduced, which are notable, but what's so exciting is it's the number of new mechanisms that are being introduced. And I'll encourage you to think about the advances in myasthenia, not so much by how many drugs there are, but think about how many mechanisms there are. And when we introduce a new mechanism of treatment, it is, like I like to say, it's not like putting a new bullet in the gun. It's like buying a whole new gun. And that's very exciting. I wish we had the same pace of discovery. I wish we had the same momentum and advances in therapeutics in other neuromuscular diseases that we treat as we do in myasthenia. But in myasthenia, you might even argue that it is an embarrassment of riches with respect to the number of treatment options, the number of treatment mechanisms, and the pipeline. The pipeline is very rich. There's a lot more coming down the line, which we'll talk about. So this is a little bit redundant, but it highlights the fact that different therapeutics affect the autoimmune attack on the muscle junction differently. So you can affect, as we say here, the production of the antibodies. You can affect the pathogenicity of the antibodies. You can affect the level of the antibodies, and you're getting to the same end, the autoimmune attack is muted because of the intervention. And this particular slide highlights which clinical trial targeted which mechanism, as some of the other ones did. So up until recently, we've had some very effective treatments, and many of you may have actually, or perhaps are still receiving some of these treatments. We've known about corticosteroids, prednisone, for quite a long time, and it was suppressing the immune system. Azathioprine or Imuran is a steroid-sparing agent for all autoimmunity or autoimmune disease, but it is an suppressing therapy. Plasma exchange, gamma globulin, mycophenolate. And then in 2017, eculizumab, which is also Soliris, was introduced. And that was, in my mind, kind of opening the door to an era of a lot of new biologics. And eculizumab, when it was introduced, was the first complement inhibitor for myasthenia gravis, and certainly not the last one. Now, the mechanisms of these various medications also are different, and I'll spare you the details of these, but I highlight this busy slide just to show you that these different mechanisms going into this period of exciting developments, we not only had multiple drugs, but these multiple drugs affected different mechanisms. Despite that, though, a lot of people were still symptomatic. And that's probably one of the largest unanswered questions, to my mind, in patients that have myasthenia gravis, is why does the same drug help one person so much more than another person when we understand that both individuals have exactly the same underlying process affecting their immune system? I don't have an answer for that. But it is something that we think about quite a bit, the idiosyncratic differences. But despite that, we have come up with, up until the introduction of these new biologics, a lot of dosing paradigms or treatment paradigms that will combine some of these because we are mixing mechanisms to try to slow down the autoimmune attack. Now, we're going to change gears a little bit here, and I'm going to talk about some of the newest mechanisms, some of the excitement that led to all of these better outcomes that I see. And the first is the concept of FcRn inhibitors. And FcRn inhibitors are a class of medications that was first introduced with the introduction of efgartigimod, which is also called Vyvgart in the field. And efgartigimod was the first FcRn inhibitor. And what FcRn inhibition means is it's a way for the body to get rid of the antibodies, to IgG antibodies. And IgG is a subclass that's very relevant in myasthenia. And reducing the level of IgG antibodies in a myasthenic patient reduces the degree to which they're affected by the myasthenia. Now, the principle of this is fascinating from a scientific point of view, I think, because we normally have a way of getting rid of antibodies, because we make antibodies all the time from a variety of things that we're exposed to. The antibody does its job, and then it's not needed, and so it's degraded. And it's, on the other hand, when it is needed, you don't want to get rid of it, so there's a way to protect the antibody. What the FcRn system does is it's a way that an antibody can shield itself or protect itself from being degraded. So what the drug does is it blocks that mechanism. And therefore, the antibodies that are circulating are vulnerable to be degraded, just like they would if you didn't need them anymore. Only in this case, the body is getting rid of them on their own. Kind of like what plasma exchange does when we physically remove the antibody, only in this case, there's no machine. It's allowing the body to get rid of its own. Now, efgartigimod was, as I say, the first therapeutic for this, but since then, rozanoliximab is the second, and now just recently, actually, since I gave the talk earlier in the year at the patient conference, the newest FcRn inhibitor was now approved for use, nipocalimab. So we now have 3 different FcRn inhibitors They're not identical, but they do work at the same mechanism. And this has been great. The way they're administered is slightly different. The way they can be dosed is slightly different. So that's perhaps a discussion if there's interest in the Q&A part. But the excitement here is that we now don't just have one, we have three, and they seem to be quite effective. Further, there's one in the pipeline, and I think there's one that I haven't put on the slide that is also in the pipeline. So it is conceivable that we will have more than three of this brand new class that was just introduced not that long ago. Now, by contrast, a different brand new mechanism is complement inhibition. Now, I mentioned it earlier when I said that eculizumab or Soliris was introduced. Interestingly, Soliris was, or eculizumab was approved for a different purpose first, not for myasthenia, for a different autoimmune disease that was not even a neurologic disease. And it was the lessons learned from that other condition that made it relevant to try in myasthenia, and it was shown to be effective. Now, complement, as I'll show you in a moment, is a process by which the antibody does damage to the membrane that it's attached to. In this case, the muscle membrane. It's kind of like the final blow. It's the landmine that blows up the area. So if you can block complement, you can significantly slow down or make the effect of an antibody less. You can slow down the destruction of the membrane, and you can make the effect of the antibody less. So we have eculizumab or Soliris. Shortly thereafter, the ravulizumab or Ultomiris was introduced. It's very similar to the drug. It just has a longer half-life, so we can give it less frequently, every other month instead of every other week. So it's offered quite a bit of flexibility for patients that were responding to it. And then most recently, zilucoplan, which is a different complement inhibitor, has also been introduced. So here we have three available drugs already, which have been shown to be very effective at treating. But there's at least four more in the pipeline. And so we expect that there'll be even more opportunity. Now, they're not identical. They just work in a similar kind of mechanism. And how they're different, I'll show you in the next slide. But there may be important differences to where along the complement cascade the drug acts. But this is incredible that we have all of these. And I mentioned the complement cascade. Complement, it's quite a complex area of the immune system. And it's similar to imagining that you have a row of dominoes, like you could line the dominoes up. And if you hit the first domino, the whole row will go down. So complement is a series of a cascade of events, the complement cascade it's called. And you could interrupt that cascade quite high up at, say, C2 or C1 or C2, and there are some drugs in development which are aiming to do that, or down a little bit lower at 4 or 5. So when a new complement drug is introduced, usually that's one of the first questions we ask. Where along the cascade does it affect the complement, and does that make a difference being higher or lower than one of the alternative therapeutics? There seems to be some idiosyncratic responses. Some patients respond more to one particular type of therapeutic in the same mechanism as another, and that is not very well understood. One of those trials that I highlighted in complement is particularly interesting, and I'm following it with interest. I'm not part of it myself, but it's interesting because it's a combination therapy. And the combination is these two drugs. One of them is a complement inhibitor, and one of them is affecting RNA metabolism. And RNA as a therapeutic is a little bit complicated to explain in a webinar format like this, but it's a very relevant mechanism. And what I like about this particular approach is that it's two drugs, it's two mechanisms together, which we hope will be synergistic. when the results come out, and it might be quite beneficial. The design of this trial is a little complicated because, as you can see, patients get one or the other or both of the medications. So it's a stratified type design, factorial, we call it, type design. But very interesting, and I expect that we'll hear about that probably next year. Another avenue of approach, as we talked about in one of the earlier slides, is B cells. So if the antibodies are produced in B cells and we can stop the B cells from producing the antibodies, suppress the B cells, reduce their numbers in B cells, then of course we would have less antibody and a higher level of function. And here we've had rituximab for a long time. Rituximab was tested earlier, not found to be effective. A lot of us have used Rituxan in selected patients and have found a benefit, and there are some current investigations which we're hoping will also support that. So reducing the B cell with a very effective medication, Rituxan, and Rituxan is used in a variety of different illnesses, disease states, even those not in neurology, quite an effective therapy. But that's not all, because there are at least 2 others in development right now. And I expect that in the near future, we're going to possibly have 1 or perhaps 2 more agents that can affect B cell production and, as a result, limit antibodies. This is an interesting trial that's also in the pipeline. And again, we expect the results to be out sometime in 26. And it's interesting because this is a new mechanism. And immune tolerance is like, it's like if you've known of somebody that got allergy shots. So when you give somebody allergy shots, you're exposing them to the thing that they're allergic to in hopes of desensitizing the immune system. Well, this is an analogous approach by exposing patients to nanoparticles that contain parts of the acetylcholine receptor. It's kind of like being immunized against the thing that was the problem in the disease. It's a very interesting approach. And again, a new mechanism that we don't have before. And if this works, this will be yet another gun, so to speak, to fire at the progression of the disease. Now, lastly, there is yet another new mechanism that is evolving in the treatment of myasthenia, as well as other autoimmune disease. And it's called cell-based therapy, sometimes called CAR-T, C-A-R-T. What these therapies do is they program the immune system essentially to shut itself off. They program T cells to shut down the production of the B cells. And there are a large variety of trials that are ongoing right now to see if this is a valuable approach to add to the treatment of myasthenia. I expect a number of these trials are done in China, and several in the US as well. But this is a very exciting area, which is rapidly evolving, not just in myasthenia, but even in cancer therapies as well. It's become very popular. So this is intentionally a busy slide because I was curious in going over my thoughts for this talk yesterday. I wonder how many active trials there are in myasthenia in the world right now. So there is a resource online called clinicaltrials.gov. It's a website. It's maintained by the government, and you can put in whatever parameters. So I said, show me all of the actively recruiting trials in myasthenia right now. There's just under 50 worldwide, 50 current trials. Now, not all of them are new drugs. Many of them are. Some of them are drugs that were already established and they're looking for other indications for them. But if I highlight just the novel drugs, just the ones that are not the things that we don't yet know about, there's quite a few. So again, underscoring the pace of discovery, the excitement that's going on in the field, and the pipeline is pretty incredible. So let's go back to the conversation, because the conversation is about exactly what we're talking about. The conversation about who's the conversation with, between you and your doctor, between your doctor and yourself, your family, and likewise other colleagues that you have with the disease. there's a lot to talk about here. There's an interesting paper that kind of underscores, it's interesting because of the approach that they took to get at this question about who's saying what about what's going on in the field. This is a paper where these authors surveyed social media, and they surveyed these chat rooms or I can't think of the other word, but these chat rooms that patients, and perhaps you're on some of these chat rooms yourself, and what they're saying. And they used an artificial intelligence tool to survey over 13,000 conversations that are going on in different chat rooms that involve patients with their disease, with myasthenia. And what they found was that in these 13,000 conversations, the majority of the time, the conversations were negative. Well, that might not be surprising because, as you might think, patients oftentimes, when they're feeling good and things are going well, they don't write in as frequently as you would write in if you were frustrated or not feeling well and looking for advice. So the majority, 60% of the conversations were negative. But what did surprise me, especially with what's going on right now in the field, that only 2% of the conversations were positive. And the content of the conversations mostly had to do with the impact on the quality of life. Interestingly, not so much on what's happening in the field. So with regard to the conversation that's changing, perhaps if this study were repeated today, this was, I think, published 2 or 3 years ago. If it was repeated today, we might expect, I would expect, that there should be or could be more discussion about what's happening in the field right now, because it wasn't with what they sampled. It was published 2 years ago, so they probably were sampling conversations that occurred 4 years ago or more, and consequently, they didn't capture this. This is interesting because this is what the folks talked about. This is what their conversation was about. So overall, most of the time, 30% of the time, it was about the diagnosis or the consequences of the diagnosis living with MG. Very little was discussed about the treatment of MG, except in patients that were on steroids or on gamma globulin. Then the vast majority of their conversations were about that. So perhaps today, this approach would reflect the change in conversation as it should, because there's a lot more to talk about now than there was even just 4 or 5 years ago. Now, this is a grading scale, a page that is listing the ALS-FRS rating scale, something that's probably common to many of you. And when you see your practitioners, probably they're asking these questions, or they could be asking these questions. And the reason for that is it gives us a snapshot of how much the myasthenia might be affecting you at the time. It's also one of the most popular endpoints in our clinical trials. We look for changes in the MG-ADL score to better assess how you're doing in the clinical trial. So in routine practice and also in the clinical trial, it has some relevance. Now, for those of you not familiar with it, I just wanted to give you an idea of when I say that there's a 2-point change or a 4-point change, it's a very significant change with regard to the magnitude of what's being affected. For a 2-point change, you can go from rarely choking to needing a gastrostomy tube because the choking is so bad. So a composite score of 2, 3, 4, 5 or more change is quite significant. The concept of minimal symptom expression it's not really a new concept. It's been around a while, but it's become a new concept because it's so much more attainable, much more easily now. The older drugs that we used before this renaissance of all these new agents, the older drugs did sometimes enable patients to reach a minimal symptom expression, which is a less than 2 on this scale. But now we do it much more frequently, and we do it much quicker than we used to with the other drugs. So, in fact, for me, that is the basis of the change in conversation when I'm meeting a new myasthenic patient. I say to my patients, my expectation is that we will find a treatment paradigm that will enable you to have minimal or no symptoms. I never said that before. I used to say our goal was to improve your situation, to improve your level of function, to allow you to do more in your life. Now I say the goal is to have you have no symptoms. Now, admittedly, we don't get there every time, but I get there a lot more frequently than I used to get there. And we try a lot of things before I stop looking, but I wouldn't really say I ever stop looking for ways to get there, because I think this is an attainable outcome for most patients, or many to most patients with myasthenia. This is some of the data that were generated from the efgartigimod trial, the ADAPT trial, and I don't have time to go over the details of the data except to show you that the blue line is the reduction in the MG-ADL score, and this bar here, these other bars are the other graphs are other measures that were tested in that trial. And the point here is that the improvement occurred pretty significantly and pretty quickly just in the first few weeks. And in fact, the magnitude of that improvement shown here in this plot here would be that 14% of the patients actually improved by 9 points on that scale, and likewise, even greater percentage improve with less magnitude. So these are very effective treatments. Other data from other trials are similar. In the case of the efgartigimod trial, 40% of the patients that responded, 40% responded to have no symptoms within that first 4 weeks of treatment. That's a lot. And that number went up a little bit in the second treatment, cycle. So this is on Rosenfeld, and there also a significant number of patients had no symptoms after treatment. And no symptoms is that 0 or 1 on the ADL score. And here again, you see the magnitude of the decrease and the speed of the decrease. That is the rate of the improvement. A lot of the other medications, I didn't spend a lot of time in the beginning talking about the older therapies, but some of the older therapies, even when they were effective, they would take 4, 6, or more months to kick in before that effective benefit came. But this occurs much more quickly now with some of the new biologics. Now, I'm just going to divert for a bit before I conclude and talk about a project that I'm involved in. I'm going to give you a brief summary of this. These are not published. This is just very recent data, but it was relevant to our discussion today. So this was a project that I was working on where a large number of healthcare providers, physicians like myself, and patients were surveyed. 200 patients and about 140 providers. And among the many questions that they were asked in this survey, these two I thought were very interesting. They asked your perception of an ADL score of 10 or greater. That's a significant amount of disability. It's not devastating, but it's certainly somebody who's affected by the myasthenia. Is that acceptable? Well, 19% of the patients said that that level of disability was acceptable to them. And interestingly, 31% of the providers said that. A little bit of a mismatch there, but you might suggest that those 31% of the providers were not oriented as well to the aggressive possibilities of minimal symptom expression to respond that 10 or more on the ADL was acceptable. Then when they were asked, what do you think the likelihood of attaining minimal symptom expression is today with what's going on in the field? 30% of the patients said it was likely, but 50% of the providers, those same providers, said that it was likely. So clearly there's a little bit of a mismatch between the perception of the patient and the perception of the provider. And maybe this is a piece of evidence in evolution. Maybe as more the word gets out, maybe as more patients ask different questions and more of the evidence is revealed, maybe these numbers will have shifted. But I thought that was a very interesting dichotomy and a trend of where we're going. So overall, there are a lot of ways to treat myasthenia. Myasthenia is unique, and I know you might not be able to appreciate this unless you were working in the neuromuscular field, but I wish we had the same level of understanding for other neuromuscular diseases that we treat. But we know why myasthenia occurs, we know how it occurs, and we've got some excellent ways to treat it. Very important in understanding and addressing patients with this disorder. We don't have that same level of understanding for everything that we treat, but myasthenia is further along than many, and we have many options for treatment. And as you know, because this slide was also dated, there are two drugs that were recently approved that are not even on this slide anymore. So this is a slide that's going to definitely have to be in evolution. But I'll caution you again, it's much easier to keep track of the mechanisms than it is to keep track of the names of these diseases. None of them roll off your tongue easily, so it's easier. And the real excitement, it's exciting enough that there are a lot of therapeutics, but the real excitement is that we're introducing whole new mechanisms of treatment as a way to address the disease. So the last thing I'll talk about before I'll wrap up for questions is, what can you do? You're listening to this talk and you're saying, gee, I wonder if I can do better, or should I be pushing for this or that, or perhaps it's not appropriate for me? All very good questions. This is my personal suggestion. Depending upon what your course has been throughout your myasthenia, if it's appropriate, set the bar higher for yourself and set the bar higher for your discussion with your practitioner. If you are dealing with symptoms, and you've been dealing with symptoms for a very long time, and you're just sort of used to it, and you say, well, must be the disease, and I'm getting by, and it's not really a problem. Think about that. Could it be better? Would it be better if you were at a higher level of function? And should you set the bar higher by wanting something more, having a higher level of expectation of what you have? I personally think all myasthenic patients should hope for minimal symptom expression. It is more attainable today, quicker than it has been in the past. And I would use it in your discussions. If you're seeing your practitioner, you say, I understand that there are new therapeutics out. Are any of them appropriate for me? Do you think that they might be a benefit? Do you think that I might be able to attain the minimal symptom expression? I think that's a valuable conversation. And then persist, because there are a lot of possibilities. And I'm sure that during the course that this webinar will be viewed, there will be additional therapeutics that I didn't mention because they came to light after this recording. So this is an evolving story, and your conversation should be evolving as well. So I'd like to stop there, and I certainly will open. I hope I left enough time for, left about 20 minutes for discussion if there are any points. And I certainly thank you very much for your attention.
Thank you so much, Dr. Rosenfeld. We do have some questions that came in, so we'll dive right into it. The first one is, are gastrointestinal issues something linked with MG?
Well, that's a great question. And the answer is we're not sure. There is a whole exciting area of research called the microbiome. And what that means is your intestinal flora, the bacteria that live and are supposed to live in your intestines, can affect things, including your immune system. But the link between the microbiome, the intestinal flora, and the immune system in respect to myasthenia is a work in progress. That is something we might learn more about, but I can tell you that doesn't seem to be affected in that all patients or most patients with myasthenia have a particular GI complaint or a particular GI symptom or sign on the exam. So it's not quite that straightforward, but with a better understanding of the microbiome and its effect on the immune system, there may be something there.
Thank you. Is the ADL the only source for patients to give feedback?
Oh, absolutely not. The ADL is just efficient because it's a quantitative evaluation, so we can compare one number to the next. But for example, I will use the ADL, but more important to me is what's going on with this person. So I often will ask them, how is the myasthenia affecting your life? What are you not able to do? Or maybe ask, what would you do differently if it wasn't for the myasthenia? How would you spend your day differently? So I think the more you share about the impact of the disease is certainly very relevant. At least it would be to me. I would hope it would be to whomever you're seeing. And I would say the ADL is just sort of a semi-objective way of quantitating your level of symptom or benefit over time.
Thank you. This next question is, are there any studies about why Mestinon works on some, but not on others?
Yeah, well, Mestinon is a unique drug because Mestinon is the only myasthenic drug that we use that does not affect the immune system. Mestinon, I didn't point this out because I'd forgotten when I showed you the slide of the mechanisms. You'll see Mestinon actually affects the result of the autoimmune problem by keeping the acetylcholine around longer to make do with the reduced number of receptors. So Mestinon does not impact the immune system. I think of it as kind of a symptomatic control. It's analogous to perhaps taking Tylenol if you have a headache. It's not actually treating the cause of the headache, but it is making you feel better. So relative to the other medications that we use in myasthenia, Mestinon is not as powerful because, again, it's affecting kind of the symptom instead of the problem. And there are patients that perhaps need something more than Mestinon, and therefore it wouldn't work, or their body is just not responding to the Mestinon. And I guess you could say the same thing in my analogy about headaches. How come Tylenol helps some headaches and not other headaches? It's the same kind of thing. So it's not unusual to have a person that doesn't get the same benefit of Mestinon as another, but it doesn't mean that they have a different disease.
Thank you. How do I start this conversation with my neurologist, especially if they tend to be treatment conservative?
Well, that's a hard question, especially hard to answer in a general webinar like this. It's a little bit easier one-on-one when I know more of the situation. But I guess in general, I would say asking the right questions in terms of saying, I became aware of this therapy or that. And currently it's a little easier because the pharmaceutical companies are advertising on television very aggressively. So more people understand what myasthenia is now because they're exposed to it in their living rooms probably than ever, because there's so many myasthenia commercials right now. And I don't think that's going to slack off as new therapies come on board. Start with that. Say, I heard about this. And then if they don't seem enthusiastic about it, ask them why. And if the answer is because what you're doing is working well, and you don't think it's working well, that would be something to share. I think we might be able to do better. But I think articulating what you want with respect to at least consider these new therapies, and then listening for the answer as to why they might not think it's appropriate. Because in your case, it might not be appropriate, but it's hard for me to answer without knowing more details about why they wouldn't want to try a new therapy if the existing therapy wasn't giving you enough relief.
Thank you. This next question is, do you see greater success, especially with newer meds, using a combination of medications?
Yeah, a lot of us are asking that question. Not yet, but that does make sense. Intuitively, that's obvious. The challenge in multiple medications is getting multiple medications covered by most insurance companies. These newer meds are a little bit more costly, or sometimes a lot more costly, and mixing them up can be problematic. So I think the answer to that question will become clearer in the next couple of years. But theoretically, that makes sense to me. It's just hard to prove that in practice right now. I know that there are some trials that are being considered for that or even underway for that, but we don't have a definite answer.
Thank you. This next one is, symptom variability is problematic. However, is there any evidence of climate worsening symptoms? Example, hot weather seems to be a problem for me.
Yes, there's a lot of anecdotal evidence that lots of things can make myasthenic patients feel better or worse. Sometimes it's another illness, sometimes it's an emotional stressor, sometimes it's a physical injury or a trauma. Some of it has to do with the number of things that affect your immune system. A lot of things affect our immune system. Stress affects your immune system. Diet can affect your immune system. We talked about the microbiome perhaps could affect the immune system. Other illnesses can affect. So temperature by itself, I don't believe has been aggressively or actively studied, formally studied, I should say. But very warm temperatures, I frequently hear that because actually, even without myasthenia, patients that spend a lot of time outside when it's very warm out, they'll often feel very tired or drained, exhausted. You don't have as much energy if you spend a lot of time in the warmth. So if you already are impaired because of the myasthenia, it would certainly make sense that it might exacerbate something that you already would have felt even without the myasthenia.
Thank you. This next question is, are you involved in any trials for seronegatives currently?
Well, there is a trial for seronegative ongoing, perhaps more than one right now. There's one active trial that is not enrolling anymore. So I'm hoping that we have an answer. But seronegative myasthenia is a very active area of investigation because, as I said, we're blessed in the sense that we understand so much about this disease. So then how are there patients that have the disease and don't have the antibody that we understand? So most of us think that seronegative patients probably have an antibody that we haven't yet discovered, or the cause of their neuromuscular junction problem is something other than the antibody. And there are some other mechanisms that you can impair the junction without the antibody. But understanding the seronegative population, which is approximately 10%, 10 to 15% of all patients presenting, is a very active area of investigation right now. So there's at least the one that I'm aware of. I think there's a second one ongoing, and there's quite a bit of basic science research devoted to seronegative patients.
Thank you. This next question is, if someone experiences minimal impairment ADLs from MG, does that suggest that their chances of having a crisis are low?
Well, kind of by definition, if you're having minimal symptoms, you're not likely about to have a crisis. However, one of the quirky parts of MG is things change over time. I took care of a patient that basically had no symptoms. His ADL was 0 for 15 years, and then presented with a flare-up that ultimately became a crisis. We could treat the crisis. It wasn't super difficult, but why after 15 years? So it's true that when a disease goes into remission, or that is, you can stay without symptoms and without treatment, that's a favorable thing, and it can go on for a very long time. But it's also true that the immune system can reactivate. And so generally speaking, across all types of patients that are more mildly affected have a much less likelihood of having a crisis than patients who have a variable course. That is, they're very affected, not affected, very affected, and bounces around a bit. That's a little bit more problematic. So it is true that to some extent, the past can predict the future, but in the case of immunoreactivity and your autoimmune diseases in your immune system, it's often hard to predict.
Yeah. This next question is, which of the treatments you mentioned are good candidates for someone with MG based on LRP4 antibodies and who also has positive results for IgG4 antibodies?
Well, I can't really give you a specific recommendation in the context of a webinar like this, but you hit on two of the subtypes of myasthenia that we are actively trying to understand better: LRP4 and other subtype antibody groups. So to my knowledge, there is not one of those classes that I mentioned that excels more. I have my own approach to how I would address that problem, but it's not necessarily a right or a wrong. It's just what my experience has been. And I think that's an interesting situation, and probably to the degree that some of the coverage of the insurance coverage of these newer drugs depends upon having acetylcholine positive receptors. So you're a little bit limited unless insurance is willing. But I don't think there's one right answer to that question. So I'm afraid I'm not going to be able to help you with that one, at least on the webinar. I think there's a variety of different approaches that might be worth pursuing.
Thank you. There's a couple of questions about what studies and medicine are new for pediatric MG.
Yeah, there are some that are new for pediatric MG. I have to admittedly, I do see children in my practice, but not enough to be running trials with the children in myasthenia. I'm trying to think of where I'm just not coming up with it. There is an active pediatrics trial for MG, and I'm trying to think of which one it is. But there are fewer of them, but I'm sorry, I'd have to look it up. I don't want to tell you the wrong information, but I'm not sure. I think that is also an area of investigation, and certainly there are fewer children than there are adults affected with the disease, but very important that we understand that better. And some of these new biologics are being tested in children.
Thank you. This next question is, if I weren't able to watch this presentation or rewatch the presentation, where could I find information about new treatments and trials?
Well, the resource that I showed you on that slide, clinicaltrials.gov, that's a good resource because it's a little overwhelming, as I showed you in that slide, because it shows you everything going on in the world. You can filter it by requesting just US studies, just studies that are recruiting. You can filter it by geography. So that's one way, clinicaltrials.gov. That's a useful website. The MGFA also does keep up with in their news feeds about trials that are going on. And then really speaking to your practitioner to see if they know of any trials in the area. Sometimes it's hard to keep track of all of them, but I think using some of the websites that are available, searching online for those, you'll find them, but they may not all be relevant. Each clinical trial looks for a particular type of patient, or perhaps it's duration of the disease, or if you've taken other medicines, sometimes it excludes you from the trial. So there's a little bit of fishing that you have to do. I use some of the references that are cited in the slides. When you go back, you can look online at those as well, and they may be updated with new trials.
Thank you. This next question is, how important is it for me to know my subtype? My antibody blood test was positive, AChR. I did not discuss subtype with my neurologist.
Well, it's important because of all the new therapeutics coming, but you're talking about a subtype of AChR. I'm curious what you mean by that. So I'm not actually certain how to answer that question, except that knowing that you're acetylcholine receptor positive is generally sufficient with our current level of understanding. If there's a certain IgG class that is relevant in the subtype, that's interesting to know, but it doesn't really impact the accessibility to treatments for you just now. So I would know it if it's knowable. Most of the time we don't know that, but it's not that relevant in terms of selecting a treatment, knowing that you're acetylcholine receptor positive by itself.
Thank you. We'll do one more question. Myasthenia causes me to become hoarse when tired, too hot, or have spoken too long or loud. Why are the throat muscles affected so much, and is this common?
Well, it is common that speech declines with repeated use, and it can be triggered both by excessive use, or as you mentioned, some of the other triggers for the same. Any muscles that are used a lot, So if you were, lifting weights or working on an assembly line and doing something physical repeatedly over and over again, perhaps you'd say my arms are affected or so. So speaking a lot, using swallowing muscles and vocal cord a lot is tiring, So I would say that it's not unusual at all. And what many myasthenic patients will do is what we call energy conservation. They'll say the same thing, but they might not say it as long. They might take more breaks. They might parse out their speech a little bit more to try to save the energy to go a longer distance. So that's not an unusual symptom, hopefully one that would respond to treatment. But by itself, it is fairly common.
Thank you. Well, Dr. Rosenfeld, thank you so much for your time today and for this presentation. We really appreciate you taking the time for the questions as well.
Sure. It was my pleasure. Thank you all very much for tuning in.
And our session will be available on the MGFA webinars page in a couple of days. We also encourage you, if you have additional questions about MG, you can go check out the website, and there's a lot of information there about trials or symptoms as well and management. Thanks. Hoping everyone has a great rest of their day.